Welcome to this training on crisis care providers and mental health advanced directives. This training is appropriate for care providers, first responders, crisis providers, tribal partners, and certified peer specialists and peer supporters. In this training, we will explain what a mental health advanced directive is, the main parts of a mental health advanced directive and why they matter. We will explain the role of a mental health agent, when they can help, and why a power of attorney form is important. We will understand how an MHAD helps someone share their treatment preferences, personal needs, and stay in control during a mental health crisis. We will also describe how crisis responders and hospital staff can use an MHAD to provide respectful, safe care that supports recovery and builds trust. Let's jump in. This training is about a very helpful tool in mental health care called a Mental Health Advanced Directive, or MHAD for short. An MHAD is a legal document that lets people plan ahead for their mental health treatment. It's used when someone might not be able to speak for themselves or make decisions during a mental health crisis. Mental health conditions can sometimes cause confusion, fear, or stress that makes it hard for a person to think clearly or explain what they need. That's where an MHAD comes in. It allows a person to write down important information ahead of a potential crisis, like what treatments or medications help them, what treatments or medications they want to avoid, and who they trust to make decisions on their behalf if they are unable to. The information in the MHAD can also help a person feel safer and calmer before a full crisis occurs. An MHAD does not just help the person who wrote it. It also helps the people who are trying to support them. Doctors, nurses, therapists, and crisis workers don't always know a person's history or what works best for them. An MHAD gives clear guidance to the care team so that they can make better decisions and respond in the most helpful way, especially during a mental health crisis or when providing help before a crisis occurs. It's important to know that an MHAD is a legal document. That means it has power. It must be taken seriously and included in a person's medical records. Care teams are expected to follow the directions in an MHAD unless there's a very specific reason that they cannot. Having an MHAD helps people stay in control of their mental health care, even during the hardest times, because it makes sure that others know how to provide support that feels right. MHADs can be a powerful tool for individuals facing mental health challenges. This might include conditions like depression, bipolar disorder, schizophrenia, or anxiety. Any situation where someone's mental health may fluctuate over time. They are also incredibly valuable for people who struggle with substance use, whether that's drugs, alcohol, or both. These challenges can sometimes lead to unpredictable or high-risk situations, especially during periods of crisis. It's important that we do not overlook the impact of trauma. People with a history of trauma, whether that's from abuse, violence, loss, or other deeply distressing events, may be more vulnerable when under stress. Trauma can shape how someone responds to a crisis, and MHADs help ensure that their care reflects this understanding. While these are some of the most common groups who benefit from MHADs, they're not the only ones. There are many other conditions and life circumstances that can increase the likelihood of mental health crisis, and that's exactly where MHADs come in. They provide a structured, compassionate way for individuals to express their preferences, outline their needs, and ensure their voice is heard. So when asked who are MHADs for, the answer is anyone who wants to be prepared, protected, and empowered in the face of mental health challenges. An MHAD is a legal document that lets someone plan ahead for their mental health care, especially in the case that there's a crisis in the future when it might be harder to make decisions or speak up for themselves. To fill one out, a person making the MHAD needs to have something called capacity. So, what does having capacity actually mean? Having capacity means the person is able to think clearly and make decisions about their own care at the time they are making the MHAD. To have capacity, a person has to be able to do three things. First, they have to be able to take in facts about treatment. For example, if a doctor explains two different types of therapy or medication, the person can understand what each one is. Second, they need to be able to compare the risks and benefits of those treatments. This means that they can think through what might help, what might have side effects, and what feels right for them. Third, they can say what they want. This could mean choosing one treatment over another or saying they don't want a specific type of care based on their past experiences. It's important to know that adults are usually presumed to have capacity, so there's no need to prove capacity before making an MHAD. So let's say someone named Jordan is thinking about creating an MHAD. Jordan had a mental health crisis as a young adult that resulted in his involuntary psychiatric hospitalization. He was diagnosed as having schizophrenia and began treatment with medications that have helped him. When he returned home from the hospital, Jordan completed an MHAD with the help of a local peer specialist. Under Washington law, it is presumed that Jordan had the capacity to complete his MHAD, and his MHAD is presumed to be valid. His diagnosis and hospitalization do not change that. If he had another crisis, providers must honor his MHAD. Washington State allows youth ages 13 and older to make their own MHAD if they demonstrate that they are able to make an informed decision about their behavioral health care. That's because in Washington, teens have the right to make some of their own choices about mental health care. So if a 13-year-old knows what helps them during a mental health crisis, they can complete an MHAD to make sure those preferences are honored. Now, let's break down what's actually inside an MHAD and why each part matters. An MHAD usually has, at minimum, 2 important sections that work together to help someone stay in control of their mental health care. Let's start with the first part, advanced instructions. This section is all about writing down the person's preferences, the things they know from experience that help them, and the things they want to avoid. This might include medications and treatments that they consent to or ones that they refuse. Life responsibilities that are important, like making sure someone checks on their kids, pets, home, who should help with bills while they're in the hospital. These instructions are personal and powerful. They help doctors, nurses, and crisis teams understand that person as a whole and give care in a way that works for that individual. The second part of the MHAD is called the healthcare power of attorney. This is where the person can name someone they trust to make decisions on their behalf if they're not able to do it themselves. That person is called an agent. Now, here's something really important. Choosing the agent is completely optional. A person can still fill out an MHAD with just their advanced instructions, and that document will still be valid and helpful. But having an agent can help make things go more smoothly, especially in fast-moving situations where decisions need to be made quickly. Together, these 2 pieces make sure the person's voice is still heard, even if they can't speak up for themselves, and that can make a big difference in how safe, supported, and respected they feel during a mental health crisis. When someone creates an MHAD, they are building a personalized guide for how they want to be treated during times when they can't speak up for themselves. MHADs can include a wide range of care instructions, each one helping to shape a more responsive treatment plan. For example, a person might describe their mental health condition in their own words, noting what treatments have worked well for them in the past. Someone might write, "When I start feeling overwhelmed, I respond best to quiet environments and low lighting." These kinds of insights help providers tailor care to what's actually effective for them. MHADs also allow individuals to express clear preferences about medication. They can give consent for specific treatments, like, "I authorize the use of Risperdal if I start experiencing hallucinations," or refuse others, like, "I formally object to the use of Haldol. It causes severe side effects for me." Support systems are another essential part of an MHAD. A person might identify someone to contact in a crisis. They could say, "Call my friend Keisha. She knows how to help me calm down." Or they could name a trusted medical provider they want to involve in their decisions. This ensures continuity of care and builds trust. Please note that the proper releases of information must be complete, signed, and present for care providers to be able to make this outreach. For those in tribal communities, MHADs can include culturally grounded care preferences that might mean involving tribal health providers or community leaders or requesting traditional practices as part of their support. These components, personal history, treatment preferences, support contacts, cultural practices, are the core of an MHAD. They turn legal documents into a living expression of someone's voice, values, and vision for their care. Now that we've talked about what an MHAD is, let's look at another really important question. When does an MHAD become active so that it can help guide a person's care? When someone fills out an MHAD, they get to decide when it becomes active. That means they choose the point at which the MHAD starts guiding their care, and if they've picked an agent, when the agent can begin helping with these decisions. There are three main options for when an MHAD becomes active. The first option is at the point the MHAD is signed. This means the MHAD goes into effect right away, as soon as it is signed by the person and either a notary public or two adult witnesses. This does not mean the person is giving up control. They still have capacity and they are still in charge of their care. They can make their own decisions just like before. If they have chosen an agent, this option allows that agent to be involved right away. The agent can talk with the person's mental health or medical providers, review the person's records like treatment history or medications, help the person think through choices and give support. This might be a good option for someone who wants help navigating a crisis now and not navigating care now and not just during a crisis. They might not be in crisis at the moment, but they want their agent to have access to support them in planning, attending appointments, or staying on track. This can be helpful. If the agent is actively informed of the person's care and has up-to-date, detailed information, it can make them more informed if a crisis occurs. For example, someone might say, I want my mom to be able to talk with my therapist right now and help me plan my care, even though I'm doing okay in the moment. Also note that even if a person does not need help right now, this option can help reduce barriers for the agent's authority when a person is in crisis, since it does not rely on a healthcare provider to determine that a person is incapacitated for them to be able to be involved. The second option is when a person is found to be incapacitated. This means that the MHAD goes into effect only if and when a healthcare provider says the person no longer has capacity. This means a doctor or mental health professional would need to evaluate the person and determine that for now, they are not able to make informed decisions about their care. At that point, two things happen. The instructions in the MHAD must be followed by the care team, and if there is an agent named, their legal authority begins. They can now make decisions, speak for the person, and help make sure the person gets the care they wanted in their MHAD. Before that moment, while the person still has capacity, the agent cannot step in. They do not have the power to act or make decisions until the provider makes that formal determination. A person might choose to say, if I'm in a psychiatric crisis and have been deemed incapacitated, I want my MHAD to activate and my agent to take over only then. This option gives some people comfort because they can keep full control of their care until they truly can't speak for themselves. The third option is when certain events or conditions happen. This gives people even more flexibility. They can say in their MHAD, my MHAD should go into effect when certain things start happening, and then describe those things. These trigger events can be anything the person knows or signs they're heading into a crisis or starting to struggle. For example, they might say, when I stop sleeping for more than 2 nights, if I stop taking my medication and start isolating from everyone, when I become verbally aggressive toward family. But this option requires something else too. The person must say who gets to decide when these signs are happening. This could be a family member, a friend, a therapist, or someone else they trust. So they might say, if my sister sees that I've been hearing voices and not taking my medication, I want her to let my provider know that it's time for my MHAD to be used. This option works well for people who may not want to wait until they're formally declared incapacitated and want to catch the crisis early, before things get too overwhelming. So, which option is best? There is no right or wrong answer. It's all about what feels right for the person and what helps them feel the most supported and safe. Some people want their MHAD to be active right away, so their agent can be involved as a support person from day one. Others want to wait until they truly lose the ability to speak for themselves. And some people know the early warning signs of a crisis and want their MHAD to activate when those signs start to show up. No matter which option they pick, the most important thing is that the person has a plan that reflects their wishes and that providers support it. When discussing MHADs, it's critical to recognize the unique consideration for American Indian and Alaska Native communities, especially here in Washington State, which is home to one of the largest American Indian and Alaska Native populations in the country. MHADs are designed to center the individual's voice in their mental health care. For tribal members, that voice is often deeply rooted in community, culture, and tribal sovereignty. So when creating and using MHADs, work to prioritize cultural responsiveness as a foundational principle. Let's break this down into several key areas. First, tribal sovereignty. Tribal nations are sovereign governments with their own laws, healthcare systems, and protocols. That means MHADs must be developed and implemented in ways that respect tribal authority. For example, if a tribal member receives care on tribal lands or through tribal health clinics, their case should be approached in relation to that jurisdiction. Coordination between state systems and tribal entities is essential to ensure that these directives are valid, actionable, and culturally appropriate. Next is the identification of tribal affiliation in connection with Indian healthcare providers. A person can use the MHAD form to identify if they are affiliated with a tribe and/or receive care through tribal healthcare providers, also known as Indian healthcare providers. This information can help to connect individuals with their tribal community and healthcare providers supporting their care. It's also important to make sure to connect people to tribal cultural teachers or community providers. Mental health care is not just clinical, it's also relational. Many tribal individuals rely on extended family, elders, spiritual leaders, and community members for support. MHADs should reflect these preferences by naming who the person wants involved in their care. This might include a tribal behavioral health provider or a cultural practitioner. Including these voices ensures that care is grounded in relationships that foster healing. Next is identification of traditional, cultural, or spiritual practices. Western mental health models often focus on diagnosis and medication, but in many tribal communities, healing is holistic. It may involve ceremony, connection to land, storytelling, or traditional medicine. MHADs should allow individuals to include these practices as part of their treatment plan. For example, someone might request access to a tribal healer during a crisis. Incorporating tribal-specific consideration into MHADs can honor the sovereignty, dignity, and cultural identities of tribal individuals. This helps move from a one-size-fits-all approach to one that truly meets people where they are. Now let's talk through some legal considerations. Under current legislation, providers are required to honor MHADs to the fullest extent possible. That phrase, fullest extent possible, is key. It means that, in general, a person's documented preferences for their mental health treatment must be respected and implemented. However, there are specific exceptions built into the law. These exceptions are safeguards. They exist to ensure that care remains ethical, legal, and safe for everyone involved. Here are the 4 conditions under which a provider may decline to follow an MHAD. First, if following the directive may violate the accepted standard of care, meaning it would go against what is professionally recognized as safe and effective treatment, then the provider is not obligated to comply. Next, if requested treatment would violate the law, the provider must refrain. No directive can override legal statutes. If the treatment specified in the MHAD simply is not available, whether that's due to facility limitations, staffing, or resources, the provider cannot be expected to deliver it. In the case of emergency, if following the MHAD would endanger the life or health of the individual or others, the provider has the authority to act outside of the directive to protect safety. It's important to note that Washington legislature intends that failure to follow these guidelines can be grounds for civil claim or for disciplinary action in regard to a provider's license. So, while MHADs are powerful tools for self-advocacy and planning, it's important to understand that they operate within a framework of clinical judgment, legal compliance, and real-world feasibility. Ultimately, the goal is to balance respect for individual autonomy with the responsibility to provide safe, lawful, and effective care. It's also important to talk about what happens when a mental health crisis escalates to the point of hospitalization under the Involuntary Treatment Act. In these situations, the individual's MHAD may not be followed. This is because the legal framework of the Involuntary Treatment Act can override the preferences laid out in the MHAD. Specifically, if a provider determines that the preferences in the MHAD are inconsistent with the purpose of the commitment or with any related court orders, the MHAD is considered invalid for that period of time. This means the provider is not legally bound to follow it. However, even when the MHAD is deemed invalid, it still holds value. Providers can use it to advise treatment decisions, offering insight into the individual's preferences, history, and what has worked for them in the past. Ideally, the MHAD should be used before a crisis reaches the level of involuntary hospitalization. When implemented early, the MHAD can help de-escalate a situation and guide care in a way that aligns with the person's wishes, potentially preventing the need for Involuntary Treatment Act intervention altogether. An MHAD does not give the agent power to admit a person into a hospital over that person's objection unless it's consented to in the MHAD. Only a judge or certain laws can decide when someone has to be admitted against their will. The agent can help speak on the person's behalf, but they cannot make that kind of legal decision alone. Note that in Washington state, a person can give the agent the power to admit them to a psychiatric hospital when they lack capacity, even if they're refusing. But still, to be admitted, the person has to have had an evaluation and meet the medical necessity requirements for admission. Let's talk through the role of the agent. An agent is someone a person chooses to be involved in their care and/or to make decisions for them. The agent is like a trusted spokesperson. They help make sure the person's voice is still heard, even when the person cannot speak for themselves. The agent does not make decisions based on what they think is best. Their job is to follow the instructions and honor the preferences the person wrote down in their MHAD. The agent can only make decisions for a person if the person has been determined to lack capacity by a professional. Once the person regains capacity, they are in charge of their decisions again. Choosing an agent is optional. A person is not required to name an agent in their MHAD. If someone does not want to choose an agent, they can still write care instructions that providers will follow during a crisis. However, some people feel more comfortable knowing that they have someone they trust to step in and help speak for them. If a person wants to name an agent, it should be someone they trust deeply. Someone who understands their values, will support their choices, and is willing to advocate for them when things get hard. For example, a good agent might be a close friend, a family member, a partner, or even a peer support worker. Someone who knows the person's history and truly wants what's best for them based on their own wishes. The agent must be willing and able to follow the directions in the MHAD. That includes what treatments the person does or does not want, who they want involved in their care, what helps them in a crisis, and any other instructions they've written. Where there is a question about what's written in the MHAD or where a decision is not covered specifically in the MHAD, the agent should do what they think the person would want. To officially name an agent, the person must include them in the power of attorney for mental health care form. This is usually included at the end of the MHAD form. The main job of the agent is to follow the person's MHAD. That means reading through the plan carefully and doing everything they can to make sure the person's wishes are respected. An agent should not guess or make decisions based on their own opinions. Instead, they should take the time to understand the person's preferences. That might include things like which medications they want or don't want, what helps them feel safe, or who they trust to support them. If those preferences are written in the MHAD, the agent is expected to follow them. But what happens in a situation if it's not covered in the MHAD? That can happen, and it is okay. In that case, the agent is allowed to help make decisions based on what they know about the person and what they think the person would want. These might be decisions like choosing a treatment center or hospital, deciding which medications are okay or not okay, helping change doctors or therapists if needed, figuring out which types of treatment the person would be open to trying. Even if these decisions are not written in the MHAD, the agent should still be guided by the person's values, past choices, and the things they've shared before. When these are unknown, the agent has a duty to act in the person's best interest. Now let's talk about the role of providers in MHAD implementation. When someone is having a mental health crisis, it can feel scary and confusing. The first goal of crisis care is to offer support so a person can feel calmer and stable as soon as possible. And MHAD can make this easier by letting others know ahead of time what helps the person feel safe and supported. That way, crisis responders can be informed about what is most likely to be effective, and they don't have to guess. Another goal is to try to avoid sending someone to the hospital or a higher level of care unless it's really needed. Hospitals can be stressful, expensive, and take someone away from their home or community. And MHAD can help prevent that by clearly listing the person's treatment preferences and early warning signs of a crisis. It also helps by sharing important information with doctors, crisis responders, or trusted supporters, like what's helped in the past and who to call. This makes it easier to get help quickly and keep everyone safe. If a care team knows what works best ahead of time, They may be able to treat the person in a less intense setting or help in a way that helps the person feel better quickly so that they can stay at home and get follow-up care from an outpatient clinic. Crisis response also aims to support the person in reaching their goals in the way that they are the most comfortable. If providers are able to do this, they can actually help prevent future instances of crisis. Ultimately, using an MHAD helps accomplish all of these goals, helping more people create MHADs and helping ensure providers ask for and honor MHADs can make crisis response easier and more effective for everyone involved. When a person has an MHAD in place and it's used appropriately, it can help build a stronger, more trusting relationship with their care providers. That's because the provider is demonstrating that they are taking the time to listen to and honor the choices of the person. The person is taking the time outside of a crisis to explain what works for them, what doesn't, and what they hope for if they ever face a mental health emergency. As a provider, following the plan shows respect. And when people feel respected, they are more likely to trust the provider, open up, and stay connected to care. MHADs can also reduce the number of times people are being forced into care they didn't choose, like being hospitalized or medicated without their input or consent. When there is a plan that outlines their wishes, providers are more prepared to offer the kind of help people actually want. This helps prevent the situation from escalating and helps avoid decisions that feel traumatic, unnecessary, or out of alignment with their values. Another major benefit of an MHAD is that it helps ensure a better match between the medicine and treatment that a person wants and what they get. Maybe they've had bad side effects in the past. Maybe one medication helped them feel calm while another makes things worse. When providers know this in advance, they can offer treatments that are more likely to be accepted and effective. This saves time, reduces frustration, and improves outcomes. An MHAD also shows us what really matters to the person, like what helps them feel safe, who they might want to be contacted, and what words or actions might make a situation worse. This can make someone feel truly seen and heard, especially during moments when they're scared or overwhelmed. And when people feel listened to, they are more likely to participate in care. Another big outcome is fewer mental health crises. When providers know how to respond in a way that honors a person's preferences, it can help stop things from escalating. An MHAD can help to catch warning signs early, respond in ways that de-escalate rather than inflame, and avoid emergency responses that may feel threatening or harmful. And finally, when people have a say in their care, they're more likely to feel satisfied with the help they receive. That means fewer complaints, fewer dropouts, and more success stories. Providers also benefit. When providers can work with a clear plan, they can feel more confident, more aligned with the person's needs, and more effective in their role. Keep in mind that MHADs are not just another piece of paperwork. They are a powerful tool for improving communication, trust, and care. They can help providers do their jobs better and help people feel like they matter, even in their most vulnerable moments. Providers play a key role in making sure MHADs are used the right way. First and foremost, providers like doctors, nurses, therapists, peer specialists, crisis workers are essential to making MHADs work. These physicians are often the ones on the front lines during a crisis or when a person's navigating the mental health system. That means that they are in a powerful position to either honor someone's plan or to overlook it. Honoring an MHAD starts with training. Every health worker who provides mental health services should be trained on how to find, read, understand, and apply an MHAD. For example, a clinician might need to know what calming strategies a person asks for. A nurse might need to review medication preferences. A peer support specialist might be the first person someone turns to in distress. They need to know what's in the plan and how to use it to guide care. It's also important that providers communicate and collaborate. MHADs should not live in one system. They need to follow a person across providers and settings. Outpatient counselors, hospital staff, emergency responders, and peer teams all need to share information and coordinate care. This may mean passing on a physical copy of an MHAD or emailing a digital copy to the appropriate team. An MHAD won't help if no one knows about it or if pieces of the team are not looped in. For example, if a person's MHAD said they want their cousin contacted in a crisis, but no one calls because it wasn't documented properly, the plan breaks down. Providers are also key to making sure the right releases of information are in place so that the documentation can be shared if a crisis does occur. Providers are educators and advocates. They can introduce people to the idea of an MHAD long before a crisis happens. Providers can say, have you ever thought about what you'd want if a crisis happened again and you weren't able to clearly speak up for yourself? Or would it help to write down what works for you when you are in distress? Providers can also reassure people that they can update their MHAD whenever their needs change. Helping someone understand their rights and choices is one of the most empowering things that providers can do. When MHADs are used in the right way, they help everyone involved in care. The person getting help feels respected, heard, and involved in their care decisions. The provider giving help has a roadmap, real insight into what works and what doesn't. And the care system gets better outcomes, including less conflict, fewer unnecessary hospitalizations, and more person-centered care. Now let's talk about information for all providers. Washington State requires crisis responders to determine whether a person in crisis that they are serving has an MHAD. It's also important to know that completion and use of MHADs is also supported at a federal level. At this time, Medicaid regulations require both outpatient and inpatient mental health facilities to inform new patients about advanced directives, including MHADs. This could look like asking a person whether they have an MHAD currently in place, explaining the benefits of having one, and/or helping with facilitating the completion of the form. Medicaid also reimburses providers for counseling patients about MHADs, whether or not they assist with completing the legal forms. This helps solidify the incorporation of the MHAD into the service delivery done by these types of providers. One of the most important parts of using an MHAD the right way is making sure that providers are truly working with the person and not just making decisions about them. Working with the person means seeing them as the expert in their own life. Even when someone is in crisis, the MHAD reflects what they've told us ahead of time about what helps them and what harms. A provider's role is to follow their lead as much as possible, using their MHAD as a guide. For example, working with the person might mean following their preferences. This could mean following preferences about who should be called during a crisis. If the MHAD says, call my sister, not my parents, then the provider should call the sister, even if the parents are easier to reach. It also means honoring their medication choices. If someone has written that a certain medication made things worse in the past, then the provider should work with the medical team to find alternatives rather than defaulting to what's most commonly used. It means respecting their environment. If the MHAD says they do better with low lighting or quiet, providers should try to make that happen whenever possible, like offering a private space instead of a crowded waiting room. It's also important to use preferred coping tools. If someone lists music, walking, or holding a comfort object is helpful, providers can offer and encourage those things before jumping to hospitalization or restraint. Working with the person also means communicating in a way that includes them, not talking over or around them. Even when the person is struggling, providers can say things like, your plan says you'd like to sit in a quiet space. Would it be okay to try that now? You wrote that hearing too many people talk at once can make things worse. How can we make this easier right now? You asked us to avoid this medication if possible. Let's talk with the doctor about other options. This approach helps the person feel seen, heard, and respected. It reminds them that they are still in charge of their own care, even when things feel out of control. When providers work with the person, they are more likely to build trust, reduce fear, and provide trauma-informed care. Crisis care is never one size fits all, and that's especially true when it comes to cultural needs. One of the most powerful ways to show respect and to build trust is by making sure care matches the person's cultural values and lived experience. When providers take the time to ask about cultural preferences and then honor those preferences whenever possible, it leads to better outcomes and more humane care. These details are often written directly in a person's MHAD, so it's important to review the MHAD carefully before making assumptions. Regardless of whether it's in the MHAD, providers should take the time to ask clarifying questions to best understand how to support a person's cultural needs. Here are a few key cultural considerations to keep in mind during a crisis. Does the person have a preference for the identity or experience of a provider? For example, a woman who's experienced trauma may feel safer with a female provider. A person from indigenous backgrounds may prefer someone familiar with their tribal customs or legal systems. If a provider cannot meet this preference, how can they still make sure that the person feels safe and respected? This could include things like letting the person know why their requests can't be met. So you could say something like, "We unfortunately do not have a woman doctor on the unit today. Is there another way I could help you feel safer? Perhaps by having a woman therapist in the room while you're talking with the doctor?" Asking them what would help them feel more at ease in the moment. Avoiding touch or eye contact if those are culturally inappropriate. You can also ask what the person's faith-based preferences are. Should prayer, spiritual items, or faith leaders be part of their care or specifically left out? For instance, some people may request a quiet space to pray or a particular ritual before taking medication. The provider can say things like, "Would you like me to contact a spiritual support person for you? Is there anything you don't want involved in your care, like certain types of prayers or groups that focus on religion?" It's also important to consider dietary needs or restrictions. This could include kosher, halal, vegetarian, or allergy-related needs. All agencies should have a process in place to make sure dietary accommodations are able to be made as needed, ensuring that the adjusted meals are just as nourishing as the regular options. We also want to consider whether there are specific cultural considerations for their care. Some cultures have clear guidelines that may impact care provided inside or outside a hospital. It's important to ask about these. A provider can say, "Are there any specific ways your care needs to be handled based on your cultural rules or customs?" It's also important to know whether there are tribal, community, or jurisdictional issues to consider. For Indigenous individuals, this might involve contacting a tribal authority or respecting sovereignty-based healthcare guidelines. These questions are essential. Every person brings a unique identity, set of beliefs, and histories into the crisis setting. Guessing or ignoring these things can create harm, which is why it's so important to look at a person's MHAD and whether these issues are addressed. These issues also highlight why providers should also be trained on how to show cultural humility and respect in their work, how to learn about the needs of different groups in their communities, whether that means learning from patients, peers, or local leaders. Now let's talk about the role of crisis responders and MHADs. When someone is having a mental health crisis, they don't always go to the same place for help. They might not even be able to explain what they need in the moment. That's why it's so important that providers across different crisis response systems know how to use the MHAD. People might show up in many different places for help. In emergency rooms, hospital staff are trained to treat urgent physical and psychiatric needs, but they may not know the person or what works for them. An MHAD can give the team clear direction. For example, it might say, "Loud voices and bright lights make me more scared. Please give me a quiet room and speak calmly." This helps the team respond in a way that feels safe and not overwhelming. Mobile crisis teams go out into the community, homes, parks, shelters, and meet people where they are. In fast-moving situations, the MHAD can help the team make quick decisions that respect the person's preferences, like calling a support person instead of transporting them right away. Police officers often respond to mental health crises, especially when there's confusion, fear, or concern for safety. When officers have access to an MHAD or are told about it by family or crisis teams, it can guide them to use calming approaches, avoid unnecessary force, and know who to call to help the person get the care they need. Some people go directly to mental health centers or walk-in centers when they feel like things are getting out of control. Staff can use the MHAD to understand what early signs of crisis look like for the person, what helps calm them down, and what medications or services they've agreed to or don't want. Paramedics and EMTs are often focused on safety and transport, but they also play a role in emotional support. If they know the person has an MHAD, they might be able to skip the ER and go to a place that the person prefers, or adjust how they talk to the person based on what's written in the MHAD. Each of these settings and service providers can benefit from reviewing the MHAD. It helps to de-escalate the situation. When providers understand what triggers the person and what helps, they're less likely to make things worse. The MHAD gives clear steps on what to do. Instead of guessing, providers can follow the person's plan. This might include specific medications, calming techniques, or preferences about who should be involved in care decisions. The MHAD also identifies key support people. It usually lists emergency contacts or care team members who know the person and can help explain what's going on. This is especially helpful when the person can't speak clearly or is too upset to answer questions. This is why it's so important for all types of providers to understand how to use MHADs and look for them whenever someone is in a crisis. In a mental health crisis, it's rare for one single provider or team to handle everything. Most people interact with several providers across different settings, whether it's crisis response, inpatient care, outpatient therapy, peer support, or community-based services. This means care is happening across systems, and without coordination, the experience can quickly become overwhelming for the person. Here's what it can look like. A person might be taken to the hospital by EMS, seen by an emergency room psychiatrist, evaluated by a mobile crisis team, and then referred to an outpatient provider all within a 48-hour period. In other cases, a person might be seen by both a mental health therapist and a primary care doctor who aren't communicating with each other. When there's no coordination, this can lead to repeating the same story over and over again, which is exhausting and often re-traumatizing during a crisis. Conflicting treatment plans or abrupt changes in medication, which can undo progress or destabilize the person further. Misunderstandings or assumptions about what the person wants or needs. An MHAD allows the person to clearly say in writing what kind of help they want during a crisis, what medications or treatments work well or don't, what calming strategies help, who they trust to help make decisions if they can't, what support people should be contacted. Now imagine this MHAD is shared across providers. Suddenly, all those teams, the hospital, the therapist, the crisis responders, have access to this same foundational information. They're no longer working in silos. They're working as a team, even if they've never met. This coordination means the person's preferences are respected across settings. Everyone is using the same playbook to support recovery, and there's less chance of disruption to stabilization efforts or gaps in treatment. Let's say a person's MHAD clearly states, do not prescribe me medication that causes drowsiness. It makes me feel panicked and I stop taking it. Without the MHAD, a provider might unknowingly prescribe that same medication again. But with the MHAD in hand, the provider can avoid this misstep, helping the person feel seen, heard, and safe. Ultimately, the MHAD is a bridge between providers and a shield for the person's dignity and autonomy. It brings clarity, consistency, and calm into a time that often feels chaotic. And it helps providers communicate better, collaborate more effectively, and truly centers the person's need in their care. Now let's talk through some tips for crisis providers. First responders and crisis teams are often the very first point of contact for someone in a mental health emergency. That's a big responsibility because how these teams show up in that moment can set the tone for everything that follows. If the team approaches the person with respect, clarity, and a sense of calm, it can help de-escalate the situation. But if the team moves too fast, makes assumptions, or ignores the person's preferences, it can make the person feel unsafe or even re-traumatized. One of the most painful things about crisis is the feeling of losing control. An MHAD gives someone some of that control back. It's a calm, respectful approach that honors the person's preferences and can de-escalate a situation clearly. On the other hand, rushing in, using force, or ignoring the person's voice can increase fear or resistance. Imagine a person has trauma connected to a previous crisis response, and the care team jumps into trying to get information quickly and forgets to explain what's happening. It could trigger panic or aggression. But if they slow down, introduce themselves by name, and explain that they've read the person's MHAD, it can create space for trust. That's why MHADs can be such an important tool for crisis teams. Letting the person know that the team is consulting their MHAD can be incredibly grounding. Imagine being in crisis and hearing someone say, "We've read your plan. We're going to follow what you wrote about how to support you to the best of our ability." That simple statement can build immediate trust and lower anxiety. This helps the person feel more in control of their care, even when they may not be feeling like themselves, and it sends the message, we see you, we respect your voice, and your plan matters. Here's a real-life application example. Let's say a mobile crisis team responds to a call for someone yelling in a park. The team arrives and find the person pacing, agitated, and not responding to questions. The team checks the system and sees an MHAD on file. It says, "Do not touch me. Do not call me by my legal name. Use my chosen name, Alex. I need 5 feet of space, and I respond best to a peer support person." Knowing this, the team can keep their distance, uses the right name, and calls in a peer. Instead of the situation escalating into an involuntary hold or a call to law enforcement, the person feels seen and agrees to go to a crisis center voluntarily. A well-used MHAD gives crisis teams a head start in doing the right thing. It removes guesswork and gives direction. Beyond good intentions, strong systems need to be in place to make sure that MHADs are used in real-life situations. This means having clear policies and procedures that make it routine for providers to ask about MHADs and know how to use them, especially during a crisis. These systems help staff remember that a person's MHAD could hold important information that can change how care is given in the moment. For example, emergency and crisis response steps should always include reminders to ask the person if they have an MHAD. This should be as automatic as asking about allergies or current medications. A provider might say, "Do you have a mental health advance directive or crisis plan you want us to follow today?" If the person is not able to answer, it's still important to keep trying to find out. If a friend, family member, or peer is on the scene, the team can ask, "Do you know if they have an MHAD?" This might help the support person remember that an MHAD exists and increase the likelihood that it's used. Medical alert tools can also help. Some people carry wallet cards, wear bracelets, or have a note on their phone's lock screen that let providers know that an MHAD exists. Crisis teams should be trained to look for these indicators, just like they're trained to look for medical bracelets or alert necklaces for allergies, diabetes, or epilepsy. Another important step is to check the person's electronic medical record, if the system has one. An MHAD may be stored in the advanced directive section. It might be a scanned document or flagged in the care plan. Providers need to know where to look and how to find it quickly. In systems that do not yet include a place for MHADs, adding one should be a priority. It should be easy to find and clearly labeled so it's not overlooked in the middle of a crisis. If an MHAD is found, the team should know what to do with it. One team member can take the lead on reading the document and quickly sharing the information that's important with the rest of the team. While that's happening, other team members can focus on calming the person down, making sure they're safe, and keeping the situation under control. Sharing key information from the MHAD helps the whole team respond in a way that makes the person feel heard and supported. For example, the MHAD might say, "Call my sister before making treatment decisions," or "Loud voices make things worse. Please speak calmly." Knowing this in the moment can reduce fear, avoid unnecessary conflict, and keep the person out of the hospital. Connecting a person with someone they trust, like an agent or other key support person, can be one of the most powerful ways to calm a growing crisis. When someone is scared, confused, or overwhelmed, hearing the voice of someone who knows and cares about them can provide immediate comfort and reduce fear. This is especially true for people who may have had bad experiences with the emergency systems in the past. An MHAD often names people the person trusts, like a family member, friend, or peer supporter who can help guide care when the person's in distress. Try to call the person's agent or other trusted support people as soon as possible. Providers can say things like, "Is there someone you trust that we can call for you right now? Your MHAD says that your cousin James is someone you want involved in a crisis. Can we try to reach him? Would it help to talk to your peer support worker while we figure out the next steps?" Making the call early in the interaction gives that support person a chance to share helpful background information and begin calming the situation before it escalates further. Note that without the proper release of information form signed, the care team can only help a person make their own call to their support people. The care team can only share information if a release of information form is signed. Letting the person in crisis talk to someone they trust can quickly change the tone of a situation. For example, hearing a familiar voice say, "I'm here and we're going to get through this together," can have a huge impact on someone feeling afraid or unsure. It can reduce panic and help them feel like they are still in control of what happens next. The trusted support might remind them of tools that have worked before, like taking deep breaths, using grounding techniques, or asking for a quiet space. If the support person can't come in person, a phone call can still be very effective. Providers can say, your mom can't get here right away, but she's on the phone. Do you want to say hi to her? Or your agent is at work, but they ask us to put you on the speakerphone so that you can talk directly. Even if the support person can't speak with the individual directly, they can talk with the care team to share insights. For example, they might say, she usually feels safer if someone sits nearby quietly. Or he needs to know what the plan is. If you can explain each step clearly, it really helps. Including someone the person trusts early and with intention can lower the risk of harm, reduce the need for restraints or emergency medications, and build trust between the person and the care team. It sends a message that their voice matters and that people are working together to support, not to control them. That kind of approach can shift the experience from one of fear and trauma to one of partnership and dignity. An MHAD is a legal document, which means it has to be followed as closely as possible during a crisis. It includes the person's own instructions about what kind of help they want in a mental health crisis. The instruction in the MHAD can be viewed similarly to verbal preferences being communicated by someone who has capacity. Here's what that means in practice. If the person is asked to go to a certain hospital or treatment center, the team should try hard to take them to that place, even if it's not the closest option. For example, if their MHAD says, please take me to Riverbend Hospital if I need care, then the team should check if Riverbend is available and make every effort to honor that choice. This matters because it may be the place where they've had good care before or where the staff already knows their history. If the MHAD lists calming strategies or things that help before hospitalization, the team should try those things. For example, if the MHAD says walking outside helps me calm down or call my mom before taking me anywhere, the team should try those steps before moving to emergency services. Even small steps like giving space, playing calming music, or bringing in a peer supporter can make a big difference. If crisis responders can't follow the MHAD exactly, or if they need to do something different for safety or medical reasons, they must write that down in the person's chart and explain why. For example, they may write, client's preferred hospital was at capacity, so client was taken to an alternate facility listed in the MHAD. Or walks outside were not safe due to severe agitation and traffic risk, used indoor sensory room instead. This documentation is required by law in many places, and it shows that the crisis responders took the person's choices seriously and only made changes for good reasons. If a crisis team locates a person's MHAD, it's very important to make sure the next team helping the person also has that information. The MHAD is not just for the crisis moment, it can guide care throughout the entire treatment process. If it's not shared, the next team may not know the person's preferences or calming strategies, which could lead to less effective treatment interventions. Here's what sharing the MHAD might look like. It might be giving a copy to the person's outpatient therapist or clinic. So if a person is going to follow up with their regular community mental health provider, the crisis team can send a copy of the MHAD through secure email or upload it to the shared electronic health record. This helps because the outpatient team can then review what happened in the crisis, what the person said helps them, and how to support them moving forward. It might look like giving a copy to the inpatient mental health hospital or facility. If the person being transferred to a psychiatric hospital is being transferred to a psychiatric hospital, include the MHAD in the paperwork that goes with them. Let the receiving staff know that this is the person's MHAD. It includes their preferences for treatment, support people, and strategies that help. The inpatient team can start off using the person's preferences right away, which may improve trust and reduce the need for more restrictive interventions. An MHAD needs to follow the person wherever they go for care. By sharing the MHAD with the next provider, crisis teams help protect the person's voice and support better, more respectful care. As previously mentioned, when possible, ensure that releases of information are signed ahead of time so that care teams can share the document. If releases of information are not in place, the person, agent, or other supports can share the MHAD with the care teams directly. Here's an example. Jasmine, a crisis responder, was called to a park where Maria was having a mental health crisis. Instead of sending Maria to the hospital right away, Jasmine called Maria's sister, who Maria named as a support person. Her sister sent a copy of Maria's MHAD, which said that talking to her sister, listening to music, and having space helped her calm down. Jasmine was able to follow the MHAD. She let Maria talk to her sister on the phone, played some soft music, gave her some space, and spoke gently. Maria was able to calm down and went home safely with her sister. No hospital admission was needed. Now let's talk through inpatient and psychiatric facilities and MHADs. When someone ends up in a mental health hospital, it's usually because they're going through an extremely hard time. They might be feeling overwhelmed, afraid, or hopeless. In those moments, it's common for people to have trouble thinking clearly, making decisions, or explaining what they need. For some people, the stress of the crisis can make it harder for them to speak up or to participate in their own care, which is why an MHAD is important. It's important to remember that many people coming into inpatient care have had previous hospitalization experiences that were scary or made things worse. They may have been restrained, forced to take medication, or not listened to in the past. Even if a provider did not mean to harm them, those experiences can leave emotional scars that make it hard to trust new teams. If someone's been hurt, ignored, or scared before, just walking through the doors of a hospital may feel like a threat. Mental health crises also cause real-life damage outside of the hospital. The person may have lost a job because of their symptoms. They may be worried about their kids or their pets, or feel like they're failing in their relationships. These stressors often add to the weight the person is already carrying while they're in treatment. This is why it's so important for hospital staff to approach care with empathy, patience, and consistency. When providers listen, explain things clearly, and show they care, it can change how safe a person feels. Even if someone has had a hard or traumatic experience in the past, a positive experience this time can rebuild trust. Using the MHAD is one way to show this person, we hear you and your voice matters here. It's a tool that can help providers make the person feel more seen, understood, and supported in a moment when they need it most. During an intake, ask about an MHAD. When someone arrives at a hospital or facility in crisis, the intake process is an important moment to learn if they've made an MHAD. Finding this information early can help teams give better, safer care and help the person feel more in control. It's important that these steps are written into agency policies and procedures. Here's some ways to check for an MHAD. You can ask the person directly. Use common, respectful language. For example, have you ever filled out a mental health advance directive? It's a form where people can write down how they want to be treated during a mental health emergency. Or, is there anything written down about how you'd like to be treated if you're in a crisis? You can also talk to family members, friends, or supporters who are with them. They might know if an MHAD exists or where to find one. So you might say, we're checking to see if your loved one has an MHAD that tells them how they'd like to be helped. Do you know if they have one? You can also look for physical signs. Some people wear medical alert bracelets or carry cards in their wallet that mention an MHAD or a trusted contact. You can say, we're also checking for a medical alert ID or wallet cards that might mention an MHAD. You should also check the electronic medical record if the system has one. Sometimes an MHAD is uploaded into a person's chart. Search under advanced directives or behavioral health documents. If the person does have an MHAD, take these steps. Once the MHAD has been identified, the next steps are just as important. The goal is to make sure the person's wishes are followed and that everyone on the care team knows what the MHAD says. It's important to get a copy. Ask the person, their agent, or the support person if they can share a copy of the MHAD with the care team. If it's available in the system, print it or flag it in the chart. Add the MHAD to the person's medical file. This helps the entire team know it exists and makes it easier to refer back to. Make sure to tell the treatment team that it exists right away. Don't assume that everyone has seen it. Make sure the MHAD is brought up during rounds, handoff, and team huddles. You might say, this person has an MHAD, let's make sure we're reviewing it during our care planning. And follow the person's wishes in the MHAD as closely as possible. This might include things like using calming techniques the person has listed, calling specific support people right away, avoiding certain hospitals, medications, or providers they don't feel safe with, or offering choices they've said help them feel more in control. By the time a person is preparing to leave the hospital, the crisis may have passed, but this is still a very important moment in their care. It's a time to make sure the person feels supported going forward and to help them plan for what to do if another crisis happens in the future. If the person already has an MHAD in place, use it to help guide the discharge planning. That means reviewing what the person has written about where they feel the safest, what providers they trust, and what supporters they want involved, as well as what kinds of services they think will help them stay well. For example, if the MHAD says the person wants to go to a specific outpatient provider, and this aligns with the person's wishes once they are stable, attempt to schedule an appointment there before they leave. If the MHAD lists family or community supports they want involved, reach out and include them in the discharge planning process. Even if some of the wishes in the MHAD cannot be met exactly, it's important to treat the document with respect and try to align discharge planning with what the person has already said matters to them. Now, if the person does not already have an MHAD, this can be a great time to help them start one. Timing is key. Only bring this up after the person is stable and able to think clearly and make decisions relatively comfortably. Once the person is stable, talk to them about why an MHAD can be helpful. Providers can say something like, "You've been through a really tough experience, and we know how important it is to have your voice heard in future situations. An MHAD can let you write down what works for you and who you want involved if things ever get hard again." You can give them simple, easy to understand information or tools about how to complete an MHAD. That might be a short handout, a list of community resources, or even a referral to a peer or case manager who can help them after discharge. You can also offer to help them complete an MHAD before they leave. If time allows and the person is interested, walk them through the beginning of the process or schedule a follow-up where someone can support them in finishing it. Helping a person complete an MHAD at or after discharge shows that the hospital is helping the person feel more prepared and empowered for their future. Now let's talk through how we can promote the use of MHADs. For MHADs to truly make a difference in people's lives, everyone involved in behavioral health care must understand what they are, why they matter, and how to use them in real-world situations. This is about building the skills and the confidence needed to integrate MHADs into everyday care. Here are the key areas staff should be trained in. First, the purpose of MHADs. Staff should understand that MHADs are a way for people to share their voice ahead of time. They let someone clearly say what works for them during a crisis, what helps, what doesn't, who they trust, and what kind of care they want. They should also be trained in the impacts of MHADs on cares and outcomes. MHADs have been shown to reduce unnecessary hospitalizations, increase satisfaction, and improve alignment between the care a person wants and the care they receive. Training should include examples and stories that show how MHADs improve safety and reduce trauma during crises. Next is provider responsibilities to follow MHADs. Staff should learn that MHADs are legal documents in many states and must be treated seriously. Training should walk through examples like, what if the MHAD asks for a specific hospital that's full? Or what if a calming technique is unsafe at the moment? Navigating conflicts with the MHAD should also be a training topic. Sometimes family, care teams, care members, or even the person themselves might say something different than what's written in the MHAD. Staff need tools to navigate those moments respectfully, prioritize the person's documented wishes, and involve agents when needed. Mental health agents should be another training topic. Staff should understand who the agent is, how they're chosen, and what their role is. This includes knowing when to involve the agent, how to contact them, and how to respect their authority while still listening to other supporters. Staff should be trained in facilitation of MHADs, especially peers, case managers, and social workers. Training should include how to support someone in creating an MHAD. This could involve using a structured guide, asking questions that help the person reflect, and helping them share their completed MHAD with their care team. Teams should be trained on tribal sovereignty and care for tribal populations. Tribal nations are sovereign governments with their own laws, healthcare systems, and protocols. That means MHADs must be developed and implemented in ways that respect tribal authority. For example, if a tribal member receives care on tribal lands or through a tribal health clinic, their care should be approached in relation to that jurisdiction. Coordination between state systems and tribal entities is essential to ensure that these directives are valid, actionable, and culturally appropriate. Teams should also be trained on cultural humility in MHADs. MHADs must be built and honored in a way that reflects each person's unique cultural background, values, and ways of communicating. Staff should be trained to ask open-ended questions, avoid assumptions, and to understand how identity and lived experience can shape preferences about care, safety, and support. For MHADs to truly improve care, agencies must go beyond education. They must build clear, consistent systems that support their use at every step of a person's journey. This includes onboarding, documentation, crisis response, and transitions of care. Let's break down what behavioral health agencies should do. They should educate staff and clients about MHADs. Agencies should provide regular training for staff on what MHADs are, how they work, and why they matter. This includes helping staff feel confident talking with clients about MHADs and encouraging their use. For clients, information about MHADs should be shared in easy-to-understand language during orientations, treatment planning, and wellness check-ins. They should facilitate completion of MHADs. Agencies should offer direct help to clients who want to create or update an MHAD. This could include trained peer specialists, case managers, or clinicians walking through the MHAD form together, offering private spaces for reflection, helping connect people with notaries or witnesses if needed. Agencies should know how to store MHADs. Once they're completed, MHADs need to be stored where the staff can access them easily, ideally in the person's electronic health record or EHR with clear labeling. For example, the EHR might have a special advanced directive tab or alert that flags when an MHAD is on file. They should also share MHADs with other providers. MHADs are most useful when shared across systems. Agencies should have protocols for sending copies to crisis teams, emergency rooms, inpatient hospitals, outpatient providers, or support workers. Note, it's important to always make sure the client has given written permission and that we are following HIPAA guidelines with any information sharing. We should be ensuring that MHAD review is part of crisis and intake steps. During an intake or crisis planning, staff should always ask if an MHAD exists and review its contents. This should be built into forms, workflows, or checklists. It's also important to review how MHADs are being used. Agencies should track how often MHADs are being completed, shared, and followed. This could be part of a monthly quality improvement process. Example areas for evaluation may include how many clients have an MHAD on file, were MHADs reviewed during recent crisis events, do staff feel comfortable using MHADs? Next, here are some resources to help increase your knowledge and understanding about mental health advanced directives. To learn more about mental health advanced directives, please check out the linked training site and the trainings that are located there. Here we have crisis support lines, including the 988 Suicide and Crisis Hot Lifeline, the Native and Strong Lifeline, and the Native Resource Hub. And here is a robust list of additional resources that help a person gain understanding about Washington law related to mental health advanced directives, as well as trainings and best practices around mental health advanced directives and also known as psychiatric advanced directives across the country. If you have questions, please contact HCA and also check out the HCA Mental Health Advanced Directive webpage for more information. Thank you.